right, everyone, we're going to get started over chapter 24. This is over psychiatric emergencies. I almost debated on not recording this one because I don't have a whole lot to add. Some of the psych disorders I do, but we'll go ahead and get started and go from there. It should be fairly quick. Now, a psychological or behavioral crisis might be the result of, these can be caused by several things. And so sometimes we think that behavioral or psych conditions are truly organic and like they're just truly mental disorders. And it can be, and it usually is. But it can also be a medical condition. Like, for example, low blood sugar can cause delirium, right? And so, like, a true psychosis can cause delirium or, mind-altering substances. The previous chapter is over toxicology. So, of course, alcohol can make people do bad things, and so, or stress or whatever. So what I want to point out is, yes, mental illnesses are a cause of psychological and behavioral crises, but they're not the only cause. There's several. And so myth versus reality, everyone experiences some form of emotional crisis at some point. Some people are more resilient than others, and different cultures handle these in different ways. But, I don't know. Let me read this. A common misconception about mental illness is that if you are feeling bad or depressed, you must be sick. That's like a big statement. And I don't agree with all of it. But if someone feels, okay, being sad or being mad or being tired or worn down or worn out, those are fairly normal emotions, right? Like, could you imagine a life where you never felt sad? Like that's really, but oddly enough, Americans want that. Humans want that. But those are normal reactions. Okay, so just because someone's sad or feeling down doesn't necessarily mean they're sick. But I'll agree with them on that. But I'll disagree with this. That my point being, I think that mental health disorders like schizophrenia and depression and bipolar disorder and ADHD or whatever, um, they are as much a medical condition as high blood pressure or as a stroke or as seizures or whatever. They're medical conditions, right? They're diagnosis, they're treatable, they're complex, they're dynamic, they vary from person to person, as does high blood pressure from person to person, as does a stroke from person to person. And so that's my point, that these are, like, unfortunately, with mental health disorders, what makes them fairly difficult is we can't run a scan of the brain and be like, oh, they have schizophrenia, right? It's diagnosed clinically. And so that, compared to a stroke, we can run a quick scan of the brain and be like, oh, they're having a stroke. And so I think that's where these become kind of difficult, like for people to understand is like, they're like, well, there's not a definitive test. There is testing criteria, but it's not as objective per se as some of the diagnoses that we like most. And so I'll just point that out. Now, um, defining a behavioral emergency. So behavior is what you can see of a person's response to their environment. And so responses can be obvious or unclear. Abnormal behavior is anything that deviates from society's norms and expectations. And so this is why I was telling you, this really depends on the society and culture that you live in. It determines what's normal and what's abnormal. And so, don't have a lot to say on that. Now, behavioral crisis or emergency is any reaction to events that interfere with activities of daily living. And so I want to point that out too, is this is also same for, very similar for disorders, and I'll talk about this. So when you start interfering with what's called ADLs, activity of daily living, these are things like brushing your teeth, getting dressed, leaving the house, buying groceries, going to work, things like that, activities of daily life. When your disorder interferes with that, that's when it truly becomes disorderly. It's a disorder, a disorderment. And so just be aware there is a difference in that. Now, psychiatric emergencies are more serious than typical behavioral emergencies. And so, a behavioral crisis or a behavioral emergency is one thing, but a full-blown psychiatric emergency is more severe. Okay. Now, according to the National Institute of Mental Health, nearly 1 in 5 Americans has some type of mental disorder. So if you're in a classroom of 10 people and look around, at least 2 of them have some type of, or maybe not even diagnosed, but some type of mental disorder. So it's very common that we're seeing this. And so can be caused by social, psychological, genetic, physical, chemical, or biological disturbances. So that's what makes these difficult is, of course, you as physicians or paramedics or EMTs, you want to treat the underlying cause. And so this is why these can be difficult to treat and sometimes impossible to treat with genetic components. These get difficult. There's a reason there's an entire branch of medicine dedicated to psychiatric emergencies and psychiatry, because it's complex. It's very complex. Now, the pathophysiology of abnormal behavior. So factors that produce behavioral emergencies or abnormal behavioral, what's AMS, altered mental status. Sudden grief. Remember, grief is not just like grieving someone who has died or something like that. It could be grief of loss of a job or just straight up grief. So just be aware of that. Emotional conflicts, psychological problems, sudden illness can create abnormal behavior, and then recent trauma as well. Now, factors that can produce, this is continued, drug or alcohol intoxication, brain diseases like tumors or neurological disorders, hypoglycemia, remember that's low blood sugar. What's the normal blood sugar? 80 to 120. Hypoxia, so low oxygen in the blood will create altered mental status. Remember, the brain is very perfusion dependent, so if it doesn't get oxygen and glucose, it will not act right, so it will have an alteration in mentation. Excessive heat or cold, that would make sense. Again, the brain is not getting what it needs. And so what they would call an organic cause of behavioral emergency, so this is altered mental status may due to an indicator of psychiatric disease. And so the organic causes are going to be like psychiatric disease, like schizophrenia or something like that. Environmental causes, again, it's alcohol, low blood sugar, stuff like that. Exposure to gases or something, something toxic. Even being in like a toxic environment, like emotionally toxic, like a bad relationship or a bad companionship or whatever, a bad job. Now, injury and illness it could also be causes, and again, substance abuse or substance related, doesn't have to be abuse. Now, the function disorders, the etiology can be traced to an obvious change in the actual structure or physiology of the brain. And so this is like, like someone who has frontal lobe injury, right? Or they have Lewy body dementia or frontal lobe atrophy or whatever. You can scan those or do tests and be like, oh, well, you have, this disorder, and so that's why you have this manifestation. And so that can happen, but it's not always that way. In fact, I'd say that's kind of rare. So examples of mental disorders include schizophrenia. We're going to talk about these, anxiety conditions, and depression. So psychiatric signs and symptoms. So remember, a sign is something that you can see or hear, and then symptom is something the patient reports. And so the psychiatric signs and symptoms reflect the body's attempt to maintain its balance in the face of physical stress, grouped according to the systems they affect. So, schizophrenia is obviously a mental disorder, but it can affect the heart and the eyes and, whatever, the lungs. And so it can be a systemic manifestation at times. So scene size up again, can't stress this enough. Your safety is first. Psychiatric patients can be dangerous. It's not a stigma. It's not me stereotyping. They can be dangerous. And so you need to be very aware of that. And a lot of times when you work on the ambulance, you'll stage, meaning you'll park down away from the call and wait for law enforcement to clear you into the scene. So from a general impression, you're going to form your general impression. Remember, this is a across your room impression. Approach slowly and purposefully. Watch for signs of aggression and agitation. And so those would be things like bearing down on their teeth, clenched fists, aggressive posture, not making eye contact, looking through you to where they're like just looking straight through you. Those are all things that are like, probably shouldn't be here right now. So you need to retreat, okay? And so again, look for the history, their posture, the scene. Are they screaming? Are they red? Are they, do they have blood all over them? Whatever. Are they armed? How are they stoic? Are they hyperactive? Are they manic? What are we looking at here? So be aware of that. Now, airway breathing, that typically it's fine unless they've overdosed on something. Circulation should be fine again unless they overdose on something. But what you have to realize is there's a real clear correlation between psychiatric disorders and overdose, intentional or non-intentional. But what I'm saying is psychiatric patients tend to overdose. So be aware of that. These go hand in hand. Now, the history taking on these patients is probably some of the most complex you will do because you have to walk a fine line of you need to get a history, but you don't want to like open up all their trauma and all their issues in your 10-minute ride to the hospital, and you're not equipped or trained to handle that. So, just use your common sense here, but focus your questions on the immediate problem. You don't really need to know why they have PTSD, what causes that, what was the past events. If they tell you have PTSD, good, that's enough. Okay, you don't need to know what and why and how and when and all that. Evaluate the potential for suicide of harm to or harm to others. Again, remember, psychiatric patients can be suicidal or homicidal. If you are one of those things or both, you do not have the right to refuse. Typically, you don't have the right to refuse medical care. You're treated underneath implied consent at that point. Actively listen and be supportive. This is the one where you should really just listen and nod your head and yes, right, and agree with them. Not saying to agree with their disillusions, but I'm saying to just try to keep them calm and just listen. Utilize the surrounding people. So family, friends, and observers may be a great help, right? To not only answer questions, but to comfort the patient. And so you could use, the family member that they're more comfortable with to, sit next to the patient or something like that. What I'm saying is family members and friends can be great historians to explain the mental illness or what's going on today, but they can also be a comfort for the patient. So document the patient's intellectual function. So again, if the patient's talking like a baby and it's a 29-year-old male, then that would want to be, you would want to document that they're, it's like regression or something like that. Now, the secondary assessment, again, this is where we do our full body assessment. This is your physical exam. And so you're going to look for the organic causes of the patient's behavior. So you're like, oh, wow, there's, I don't know, there's needle marks all over the patient's arm. Well, you might think, okay, well, that's likely causing their delirium right now. Or, oh, the patient smells of whatever, marijuana, and that's why they're stuporous or whatever. So just be aware of that. Obtain vital signs, pulse oximetry, all that stuff. Now, reassessment, you would want to reassess these patients without being annoying. One thing I'll say about reassessment is I found sometimes with irritated patients, it's best to take the blood. Okay, so you probably don't know this, but when we transport patients, we usually leave them hooked up to the monitor. So where like the pulse oximetry and the blood pressure and sometimes the EKG pads, they're all connected to the patient. And patients who are having psychiatric disorders tend to not like that. So sometimes I would just take a set of vital signs and take them off. And if I needed another set in 15 minutes, I'd put them back on and take them off with the patient's consent. And sometimes I've had patients where they're like, no, I'm not letting you take my blood pressure, but I'll let you take me to the hospital. That's fine. Take them to the hospital. Okay. Remember, they have the right to refuse. Generally, that you have the right to refuse any part of medical care, including vital sign assessment. And so give the receiving hospital advance warning. Typically, these patients, they're going to require their own room almost always. Sometimes it's a specialized room like a padded room or psychiatric room where they remove objects to where they can't hurt themselves in there. And there's usually a camera watching them. And sometimes they require what's called a sitter, to where someone sits with them one-on-one. So they'll have like a tech or someone like that sit on this patient and watch them to make sure they don't harm themselves or someone else. And so if restraints are used, say what type you're using and why they were used, and we'll talk about restraints here in a minute. Now, so maintain safety for yourself first, and then the patient. Place the patient on the stretcher with the straps in place. Remain with the patient at all times. Avoid judging the patient. And try to be, and this is what I'm talking about, be careful getting in their grill or getting too close to them. They could grab you. These patients can be unpredictable. So again, I'm not trying to stereotype them. I'm trying to keep you safe. So just be aware of that. Now, acute psychosis is a condition you see pretty often. And so it's a state of delusion in which the person is out of touch with reality. They're psychotic. And so, there's a lot of causes of this, but, you could have a acute psychosis from mind-altering substances like ketamine or phencyclidine, PCP, or, even K2 or whatever. I don't know. You could have mind-altering experiences, so you're out of touch with reality. Intense stress can induce psychosis. Delusional disorders, right? So people think aliens are coming after them or something like that. Schizophrenia. We're going to talk about schizophrenia. And some episodes last for brief periods, others can last a lifetime. So psychosis hopefully is short, and it usually is, but it can last a lifetime. Now, schizophrenia, on your homework, we'll have you watch this video. It's very interesting of Anderson Cooper. So schizophrenia is hallmarked by first auditory hallucinations. So that's like someone's talking to you and stuff like that in your ear. So that's one. And two is episodes of mania. to where they're manic. And so they're like really grandiose. And so they think they're bigger than they are. They make bad financial decisions, bad life decisions. And so that those are episodes of schizophrenia. And so schizophrenia is a lifelong disorder typically, or once you have it, it doesn't go away. We can treat it, but it's not a cure. There's not a cure. And so it's a complex disorder, is not as easily defined or easily treated. Um, and so typical onset occurs during early adulthood, with symptoms become more prominent over time. And so the symptoms are delusions and hallucinations. And so there are, of course, episodes of mania, but it's these hallucinations. So the risk of suicide in schizophrenic patients are really high. And so what they did in the social experiment, they put these headphones on like Anderson Cooper, and like there's someone whispering in his ears like, "Psh, psh, psh, you're stupid. Psh, psh, go kill yourself." Psh, psh." And so like it's very disorienting for people. And he does it for like 10 minutes, and at the end he's crying because he's like, I can't imagine living like this forever. And so it illustrates what these people, just a small portion of what these patients go through. And so we'll have you watch that. It's not very long. It's probably like 5 minutes, and we'll talk about it in our discussion in class, with what we think about it. So a lack of interest and pleasure, you can see that schizophrenia. There's different forms of schizophrenia that fall into some category, but you don't really need to know what those are. So again, it's a very complex diagnosis. And so for psychosis, patients are usually incoherent. They can be incoherent or rambling in their speech. So they'll be, you're trying to talk to them, hey, sir, what's going on today? And they're like 49 Mets football fan, Super Bowl, Taylor Swift, Rolls Royce. And so like that would be just rambling and incoherent. And so just be aware of that. You can also see what's called pressured speech, where they're really trying to, and they're really trying to tell you what and they're like they're really pushing to get their speech out. And so a thorough examination of the patient is rarely possible in psychosis. I would object to that. Depends on how what's going on. Of course, you want to get an exam, but I wouldn't go so thorough as to irritate them. Now, principal objective is transport. And so they have this Coast Map mnemonic. And so I don't know. I screenshot it from y'all's book and put it in here, but I don't really use this mnemonic, but I put it in here. So I guess this is assessed like consciousness, orientation, activity, speech, thought, memory, affect, mood, and perception. So again, I don't really use that, but it's in here, so I don't know if it could show up in a Q bank, but I doubt it. Now, the management for psychosis, usually, okay, if someone's psychotic, like they have psychosis, reasoning, okay, normally we reason with patients, but you can't always reason with someone who's psychotic. You could try, but I wouldn't try too hard, because you're usually not going to be successful and you could just irritate them. And so, um, uh, you could you have to come to your diagnosis. And so just be direct and simple and consistent and firm, and these are how you handle these people, but also be kind, but be simple and don't use big words, and be consistently kind. And so usually, even for paramedics and physicians, we don't use a lot of drugs to treat psychosis. A lot of times you want to treat the underlying cause of what it is. Okay, and so suicide, this is a leading cause of death in the United States. Depression is a very significant factor to leading to suicide. And so it's a dangerous misconception, yet common, that people who threaten suicide will never commit it. No, if someone says, I want to kill myself, you should believe that. You have to believe that. You're required to believe that. So keep that in mind. And be alert to warning signs. A suicide patient may be homicidal as well. I keep telling you all that. So just they may take you with them if they try to kill themselves. Now, agitated delirium. So delirium is like where you're delirious, right? So like you're not in cognitive function, right? You're not with reality. So delirium is a condition of impairment of cognitive function that can present with disorientation, hallucinations, and delusions. So you're delusional, you're delirious, very similar to psychosis. In fact, for our intents and purposes, they're almost the same thing. And so if you can approach the patient, be calm, supportive, empathetic. What is empathy? Empathy is walking a mile in someone else's shoes. So keep that in mind. Limit your physical contact, and use careful interviewing to assess the cognitive function. So, again, this is a weird chapter. I don't have a lot to add. Now, mood disorders, we see a lot of these, and these are usually not as emergent, but like an emergency, but they do happen. And so changes in affect are accompanied by other symptoms which cause a major disturbance in the person's ability to function. So the emphasis on this is being the word disorder. Remember, these disorder means it's, as far as psychiatry is concerned, disorder means it's interfering with their activities of daily living, their job, their hygiene, their daily living. And so you can have like bipolar disorder or manic behaviors or depression or schizoid disorder. There's all these types of disorders that you can get, and we don't really need to know the names and what they are and how to diagnose them, but just know that the word disorder, what I want you to know is the word disorder means it interferes with their activities of daily living. We've all experienced episodes of mania to some degree. We've all experienced episodes of some form of depression, being depressed just a little to some degree. Now, whether that was full-blown bipolar disorder, no, but probably not. But just know that when it affects the activities of daily living is when we start chunking on the word disorder, not until then. Now, neurotic disorders, these are anxiety and mental disorders in which the dominant moods are fear and apprehension. And so we'll show you what these look like. Generalized anxiety disorder, this is very common. Patients worry about something for no real, to them it's a particular reason, but in reality it's not a real particular reason, or the worrying is unproductive. And so they're just worried. These are the people that are just worried. And so just be aware that this does exist, a generalized anxiety disorder. They're just worried. And there's treatments for this, and there's therapies and stuff like that. But, we've all heard of phobias. Like, a phobia means you're afraid of something or you have fear. And so, like, you could have claustrophobia where you're afraid of confined spaces, or, arachnophobia, you're afraid of spiders, or whatever it is. So just be aware of that. So it's a dread or a fear, of something, a situation. It could be a social situation or a thing like a spider, or it could be a tight space, so it just kind of depends. Public speaking. Now, a panic disorder is a little different than a phobia. A panic disorder, okay, phobia is fear and like apprehension and dread, but panic is panic. So a panic disorder is when you characterized by sudden, usually unexpected and overwhelming fears of fear and dread, but it's like a panic. It's beyond, oh, I really don't want to do that. It's like panic. So you'll have physical and emotional response to this, like sweating and tachycardia and hyperventilation and carpal spasms and stuff like that. So just be aware, that's a slight distinguishing between the two. We're almost done. So mediological considerations, medical and legal considerations are more complicated with a patient undergoing a behavioral crisis or psychiatric emergencies, right? And so you need to be careful with the legal ramifications of allowing a psychiatric patient to refuse, like someone who, I'm not saying they always can't refuse, but you need to be thinking like, oh, this could have consequences. So this is where you want to maybe involve medical control or law enforcement or a supervisor or a witness, or document it well, or a body camera or something like that. And so mental capacity can take forms in like, someone could be mentally incapacitated, not just because they can't answer your A and O questions or they're unresponsive, but severe stress. They keep mentioning this, that I don't think Americans or even practitioners appreciate, is that severe stress can incapacitate someone. And so, and stress comes in many ways. It could be from your school exam, or from like a stressful situation or something like that. But just be aware of stress. It's very interesting to me how people react under stress, and depression as well can be a form of mental incapacity. Now, this is what I was talking about earlier. Implied consent is when the patient who is mentally incompetent, or implied consent is with a patient who is not mentally competent. So it's not mentally competent. And so what happens is, if someone is not mentally competent, they're just rambling and they have pressured speech and they don't know what today is, and they're talking about killing George Bush or something like that, then you need to be thinking like, oh, okay, well, this patient's not mentally competent. Okay. And so just be aware that in that scenario, test question, where you would treat them, it's underneath implied consent. It's implied that had they been in a normal state of mind, they would want you to take care of them. And so it's implied consent. Same for an unresponsive patient. It's implied that they would want your care. And so, under non-life-threatening situations, emergency medical care or transportation may be delayed until proper consent is obtained. Usually, these aren't very emergent, where like you really got to hurry. So, my advice on this is take your time and be thorough, and don't move too quick. Chaos is contagious, so you need to be the calm to the storm and bring everything down to calmness. Contact medical control or follow local protocols when in doubt. Um, Now, the limited legal authority. The patients have patients inherently as Americans, freedom is, you have freedoms, constitutional rights. You have the right to refuse care generally. Now, this is where it varies state to state with, well, when can law enforcement detain you and do a mental detention, or in California do a 5051 or whatever it's called. There's different like rules and forms that vary state to state, and the National Registry will not test you on that. But you need to know that uh, inherently, you have the right to refuse any part of medical care, assessment, treatment, or transport. There are exceptions when you lose those rights, or those rights are in severe mental capacity, or drug impairment, or alcohol impairment, or something like that. That will vary state to state when you can step in, and you'll figure that out when you start working in the field. So when in doubt, this is what I was talking about. When you're in doubt, and you're like, oh man, my gut tells me I shouldn't leave this patient here. My gut tells me that I really should force them to go to the hospital. Call a supervisor, call your medical director, call medical control, call law enforcement. And if all of you make scene and you're like, hey, the patient has the right to refuse, and while I think it's a bad decision, they legally meet the right to refuse, then that is their right. So just be aware of that. Patients have the right to make bad decisions sometimes, as long as it's a legally bad right. Like you have the legal right to make bad decisions. So, no, with that is what I keep saying. When in doubt, it's a lot better for you to transport and treat someone under implied consent than to just like, they signed my AMA, they knew who the president was, they knew where they were at, so we're out of here, right? And just leave them on scene. So, when in doubt, treat and transport. That's the book's opinion. That's Hunter's opinion. That's going to be your medical director's opinion, and that is the law's opinion. So when in doubt, err on the side of treatment and transport. Now, restraints, we'll go over this in class if we haven't already. Typically, we do this in patient, like when we moving of patients and lifting of patients. But if not, we'll refresh this in class. Do some scenarios. So okay. So restraining someone is very serious. Okay, you're taking away their constitutional rights, and so it has to be ordered by a physician, a court order, or a law enforcement officer. And so you're like, well, there's usually not a physician on scene to tell you restrain them. Well, that's where standing orders come in, right? That would be like a written order of like, under these scenarios, you can use soft restraints. These are called soft restraints right here, to restrain the patient. Those are called soft restraints. And so um, one thing I want to point out is the way they're restraining this patient. Notice that the patient's hand is here. There's one at his side and there's one at his head. It's because you can't lift up as far if there's one at your head and one at your side. So it further immobilizes the patient from like moving up and trying to bite and stuff like that. Now, you can have legal actions legal actions can involve charges of assault, battery, false imprisonment, and a violation of someone's civil rights. So now, remember, assault is the unlawful. Assault is when you make someone fear. So, like, if someone were to like raise their fist at you, right, that would be considered assault. If you have reasonable fear that they were about to punch you, even though they didn't touch you, that could be considered assault. And then further, battery, the next one, that's the unlawful touching of someone. So, if someone were to come up and touch you without your consent, that's technically considered battery. Now, in Texas, we don't really distinguish between the two. It's just assault and battery is one thing. And so that varies from state to state. Now, false imprisonment, this is like kidnapping, right? So again, if you're to tie someone down to your stretcher and that you have no legal right to do that, that could be considered kidnapping or false imprisonment. And then again, when you do this, when you restrain someone, you are taking away their civil rights. Now, if you violate that and do it illegally, that would be a violation of their civil rights, and that is a crime. Restraints, use restraints only to protect yourself or others from bodily harm. So these should be, I wouldn't say a last resort, but you should like think 2 or 3 times before using them. They do have utility. I do restrain patients. I have restrained patients. As a paramedic, I like to chemically restrain patients. It's a lot easier to give them medicine to just make them sleep. It's safer generally. And so just be aware of that. We'll talk about how to properly do this, okay? In fact, it'll be interesting. There's currently a case that's, I don't know if it's been settled yet. I need to look it up. That the paramedics restrained a patient face down. Like, so they laid him on the stretcher and prone, like face down on the stretcher, and strapped him up real tight with some blankets. Well, the patient died en route to the hospital. They were charged with murder, not manslaughter, but murder. And so it'll be interesting to see how that case comes out. But this is an example of why you need to know how to properly restrain someone. We don't ever restrain someone face down. We don't ever restrain someone with something on top of them, like a backboard. Ever. Don't ever do that. You will go to prison for the rest of your life. And so, in subduing a disturbed patient, you want to use the minimum force necessary. You don't need to hot rod someone and tune them up. Okay, that would be assault and battery and unethical. So it's just the minimum amount of force necessary to restrain them. Okay. And when I worked at Cook Children's, for example, we had this class called CPI, where we went to like a 3 or 4 day class with like mats and everything. Like you had to demonstrate it to know how to properly restrain people. It's a big deal to restrain someone. Now, have and document witnesses in attendance. Okay. Now, these last few slides will be about PTSD and then veterans. So PTSD, post-traumatic stress disorder, emphasis on disorder. Okay, guys, everyone in America has some form of post-trauma. You've had trauma in some way, whether you're bullied, you've seen some bad things, whatever. You've had some type of trauma, and that could at times cause you stress, and that's called an acute stress reaction, or acute stress, acute stress reaction. And so that's normal. Okay, you've been exposed to things that are traumatic for you. It's when they become disorderly is when you throw this D on there. That's when it's a post-traumatic stress disorder. Okay, so post-traumatic stress disorder can occur after exposure to or injury from a traumatic event. Okay, this could be a car wreck, this could be bullying, this could be seeing someone die. This could be a lot of different ways. Okay, and the trauma could have occurred recently or a long time ago, or it could be something that occurred multiple times over and over again. Okay, sexual abuse would be an example where this could lead to PTSD. And so the signs and symptoms are helpless, and this varies from person to person, but helplessness, anxiety, anger, fear, nervous system arousal, so fast heart rate, fast breathing, increased temperature, right? So they're going to get that sympathetic, like that disorder, like that panic, okay? And so this is where you'll get the sympathetic signs and symptoms, right? An increased heart rate, your pupils dilate, systolic blood pressure increases, senses are sharpened, and mental acuity is heightened. What does that sound like? It sounds like someone's about to go fight a bear. And so that's why this happens. And so this is where this can become disorderly. And so with this, unfortunately, there's guilt and shame and paranoia and hostility and depression because of this response. It makes them feel guilty and shameful, and this paranoia, like, oh, is this going to happen to me again? And this hostility and depression. So it's really a pretty unfortunate disorder that's fairly common. And we can see, not a stereotype, but you can see this in veterans, returning combat veterans. So veterans that have seen combat, they could have PTSD. So they require a unique level of understanding and compassion. Every patient deserves compassion, especially combat veterans, and specialized attention. Take time to establish the history of this patient. Be careful, be slow, take your time, be thoughtful, be empathetic. Approach the patient with sensitivity and respect. Be careful with how you phrase your questions. Be careful if you're too direct with these questions. Why do you got PTSD? Oh, did you go to combat? Did you kill anyone? Like stuff like that. Like, you don't need to ask all that. So just be mindful of how you ask your questions. Be very kind. So when treating a combat veteran with PTSD, try to eliminate excess noise. This is where it's really best. You get a fire engine with 4 or 5 firefighters, and you and your partner, and it's like, you know what, guys, you can go. This guy can walk. We appreciate y'all's help. And just to eliminate all that noise and extra stimulation for these patients sometimes. So that's it for this lecture. I know that was pretty quick. I mean, I really just don't have a lot to add. I do actually really like psychiatry, but I don't want to tell you a bunch of stuff you don't need to know because they don't test you at a very crazy level. So with that, just remember, it's always going to be safety first, and then usually just supportive care, and be compassionate and empathetic, and that'll guide you through 99% of not only the problems on your exams, but with the patients as well. So that's it. Thanks for your time.